Assalamu alaikum. Inshallah, today we will talk about accidental pediatric ocular trauma. Inshallah, Dr. Riyam, Rashid, our consultant, ophthalmologist from Iraq. Uh, Dr. Riyam Rashid, she did her fellowship in pediatric ophthalmology and in neuro-ophthalmology in Moorfield Hospital, and now she works in Emirat. Please, Dr. Riyam, the microphone is with you.
Assalamu alaikum. Good evening, everyone. It's my pleasure to present lecture about accidental pediatric ocular trauma. Why we mentioned specifically that's accidental because our next lecture, inshallah, will be about non-accidental or child abusive ocular trauma, inshallah. Here's my disclosure. There is no financial interest in any of the mentioned products in my lecture. Starting with the classifications of ocular trauma in children, might be not not familiar to everyone that we classify the ocular trauma in children according to the zones in each categories, whether closed globe or open globe. And closed globe injuries, when there is contusions, lamellar laceration, superficial foreign body without open wound. There is no cutting wound, no open wound at all. The globe is really and actually closed. An open globe injury, usually either laceration or rupture. Laceration can be classified into penetrating injury when there is inlet, there is no outlet, perforating injury when the mechanism is causing both inlets and outlets in the globe. There is open globe injuries that caused by a plantar trauma. The mechanism of injury is different, but the globe is open, what we call a ruptured globe. So open globe injury can be either laceration when the sharp object causing the injury, or plantar trauma related open injury, what we call a ruptured globe. Here's the general classification of our trauma in pediatric eyes, whether closed or open. We'll go through each of one according to the zones. In a closed globe injury, we have to specify where exactly the injury is. As in zone one means that the injury involved the walls only, either the conjunctiva or the cornea, or the sclera, or any two or three of them. We are here to classify it's closed, so there should be no cutting wound, no open injury. So the wall is involved, but there is, we are going from outward inward, like the walls are involved, but there is no injury inside the eye itself. Going inward into zone two, which means anterior part of the globe, like the anterior chamber, the lens, the posterior chamber, and ciliary body, pars plicata. Actually, the zone two means that we are going back from the back of the cornea till the posterior capsule. This is what I always remind myself about it. Like it's zone two started from the posterior surface of the cornea or the sclera till the posterior capsule of the lens. All these structures in this area are within the zone 2 injury. Zone 3 injuries means the injuries are posterior to the zone 2, which involve the vitreous, retina, choroid, and optic nerve. Before going to the globe injury itself, we have to head firstly to the eyelids and lacrimal gland, lacrimosory structures trauma. So here as well, if it's closed or open, accordingly, we have to assess the patient. In closed injury of periocular structure, the lids and the lacrimal, we have to look carefully for these points. We are evaluating the eye anyway, so ocular structures should be evaluated thoroughly, like any other ocular trauma. Even if we think that the trauma is involving the periocular structure or adnexia only, we have to look carefully for associated ocular injuries. So ocular structures should be evaluated thoroughly, and we have to evaluate the trauma. Even if the mechanism is blunt, we have to look for a rupture injury, like whether it's open or closed. Evaluate carefully, then check the motility. Don't forget to check the motility and eyelid and lacrimal trauma. It's very important to check for any associated orbital injury or eye globe injury, which involve the rectus or oblique muscles. Neurological examination is very important. Cranial nerve examination, as we are checking the motility, we have to check the pupil as well. We have to look for any signs or symptoms associated with the injury and related to orbital hematoma or orbital edema. If it's possible to evaluate the optic nerve appearance, would be better. Acutely, you might omit this. We just consider the pupil reacting. We will repair the lids, or at next year we'll go back to full thorough examination again. In this picture, we have the child having eyelid contusions, which is closed eyelid injuries. This picture has been taken from Taylor, pediatric. He is 9 months. She is a girl, 9 months old, and the first picture showing the girl has injured herself, hit her orbit with something hard. The second picture, it's much more severe contusion, causing ecchymosis rapidly increase to cause complete ptosis and closure of the globe. Sometimes you need to use the eyelid retractors carefully to examine the eyeballs and check carefully if there is any associated eye injury. And such injuries with severe eyelid swelling that preclude examination of the globe, it's painful to use the eyelid retractor without anesthesia. Topical sometimes are not enough. You might go with a general anesthesia to check the eye and explore the associated injury if there is high suspicion of injuries, or the orbital neuroimaging showing suspicion of eyelid being opened. Eye globe being open. Here's the acute measures that we have to go through for eyelid contusions. Don't hesitate when you feel it's indicated to do orbital imaging. CT scan always is informative. You can get too many information that have been missed from your assessment initially. If the lid is really swollen and you cannot assess the globe and you cannot assess the motility, and you suspect something in the orbit as well, orbital edema is severe, or orbital hemorrhage is suspecting, you have to go with orbital imaging. CT scan is ideal in acute measurement, and if there is suspicion of intraorbital or intraocular foreign body, this might be helpful as well. Ice application is surprisingly very helpful in such cases. If you have only contusion, no open injury, nothing to be repaired, and you're sure that your globe is intact, you can discharge your patient after giving them the baseline measures of analgesia and anti-emetic, and you can discharge him safely on ice application or cold compresses. Subacute management of eyelid contusion include observation of the healing. If there is any blunt trauma-related injury inside the eye, look for microscopical hyphema, for example, for traumatic cataract that might develop later. Look for any fundus injury, any retinal tear, detachment, dialysis. And you have to moisturize the skin as well in cases of severe edema to prevent ulcer or further erosions. So moisturizing of skin is helpful. Long-term management focus on vision development, prevention of any amblyopia, any strabismus that has developed. Look for the cause, treat temporarily with a prism or Botox injection. Look for any muscles that had been injured, anything else to be corrected in the meantime, and prevent the development of strabismic amblyopia as well by occlusion and other amblyopia measures. Traumatic ptosis that might develop later due to dehiscence of levator or cicatricial due to injury-related or suture-related complication, or nerve damage like infraorbital nerve damage that causes paresthesia. These points should be addressed well, should be first identified and then addressed well. So from closed lid injury, we are heading to eyelid laceration. As per the globe, there is closed and open injury related to the adnexia. So eyelid laceration are classified into non-marginal, marginal, or lacrimal system involving. All three categories can be found in the same patient, but we have to classify the wound exactly, the location, the size, and the whether it's marginal or not, or whether it's related to lacrimal or not. As in this patient, as I mentioned, we can find more than one category in the same injury. This patient has, unfortunately, two wounds in the same side, like right upper eyelid. There is marginal lid wound, and in the lower eyelid, the same side on the right, there is non-marginal laceration of the lid. How to manage this? Let's consider that we don't have any other globe injury, and our main problem is lid lacerations. The wounds should be clean, well, and I missed it, and I did it a lot, so I have to tell my colleagues that we should remind ourselves not to forget to check inside the wound if it's deep. The Q-tip is very accessible and everybody has it in ER or in the OT if the patient is under general anesthesia. Just grab your Q-tip and look for any foreign body inside the wounds. Because sometimes even very simple, usually the mechanism of a trauma in preschool age is not really clear. The child will not give you enough history. The family might not be there involved in the same time. So you can't guess whether there is foreign body inside the wound or not. So as per the lower lid of the right eye, in this picture, the doctor is trying, the physician is trying to check if there is any foreign body inside the laceration, as the laceration is not really superficial. So using the Q-tip, then explore any other associated complication under general anesthesia or under topical anesthesia according to the compliance of the cooperation of the child. So the wound is being explored, showing extension or not. Is there any orbicularis muscle injured or not? Because if we find that the orbicularis has been violated, we have to suture this in layer. The orbicularis should be sutured. If we don't suture the orbicularis, we are exposing the patient to get notch after healing of his wound. The orbicularis can be repaired very easily in layer, and then the lid closed later. Here's what I was talking about, the layer suturing. What type of suture we're using? For orbicularis muscle, typically we are using absorbable sutures from 6 to 8. I personally use 6-0 or 7-0 vicryl. But it's any type of absorbable, and from 6-0 to 8-0, any of them, if it's available for you and accessible, you can just use it. For the margin, we can still, like adults, go with silk, the traditional silk that can be used for skin and margin. But the thing that you just put in your mind, these are children. You might need for general anesthesia just to remove the suture, the absorbable suture. So that's why in younger children we prefer to use absorbable, because non-absorbable might need general anesthesia to be removed. Here's what we are doing in the emergency room. We are trying, the laceration is not marginal. We can close it with the glue, with the steno-acrylate glue. It gives better cosmetic alignment sometimes. because there is no scarring, no nodes that's applying pressure to the lid. And also, if you are not very keen on using general anesthesia to suture the lid, you don't have any further injury, why we have to give the patient anesthesia for only non-marginal laceration? So we can go with the glue and check the patient within 24 hours before the 24 hours of injury has ended. If it's closed and aligned, that's it. So it's safe alternative in non-marginal wound. Talking about marginal lid wounds, here's how to close the marginal eyelid laceration without the lacrimal system being involved. Actually, approximation of the edges of the laceration can be achieved with vertical mattress suture. The vertical mattress placed within the tarsus with non-absorbable, for example, polyglectin 60 should be 60, because it's very clear. And the node should be buried within the tissue of the tarsus. Then further suturing of the tarsus can be done, and the closure of the skin of the lid done at the end. So in the last three slides, we explained the marginal and the marginal wound injuries and lid injuries and how to address them. Here's the third category, which is the eyelid laceration with lacrimal system being involved. We have to check if there is a lid laceration, lacrimal system suspected to be involved. We have to check for the patency of lacrimal system and if there is any injury. So we can do that very easily by injecting the fluid from the upper canaliculus to check the lower and vice versa. So we can use the other canaliculus to check first one of them. If there is suspicion of canaliculus injury, you cannot see the canaliculus, you can inject viscoelastic fluid or use anifluorescein and check the stain if it's coming or not. And then you have to head for the repair of canaliculus, as in this picture. If you suspect injury or you find out that the distal end is not there, use the viscoelastic injected to nasal subcutaneous tissue to spread the tissue and see the lumen of canaliculus, or use the big tail probe to introduce into the punctum and emerge through canaliculus to see the canalicular system. Repair of canalicular system is very important, and to prevent epiphora post-op. The repair should be done with help of intubation. Lacrimal system is intubated, and we can use mini monoca, as in this picture, showing that the lower lacrimal canaliculus has been violated. The mini monoca has been inserted through the punctum, and then suturing of canaliculus tissue and then the skin over it was done successfully. In the last picture, figure D, showing the child a few months post canalicular injury being repaired without any scarring or complication. So talking about the adnexia, we have to orbital trauma is a very big subject. We can't address everything, but the most important emergencies that should be everybody should be aware about them and should exclude them, even if he is not pediatric ophthalmologist, because their treatment are vision saving, and sometimes even life-threatening complication can happen if not addressed or identified well. So the first one is orbital contusions or orbital compartment syndrome. If there is blunt trauma to the orbits causing contusion, and the orbital edema or hemorrhage are enough, they are severe enough to cause dangerous compression on the globe. This can injure the optic nerve and can decrease the vision in like maybe in 20 to 30 minutes. So check the vision if it's possible, if the child is cooperative. Check the relative afferent pupillary defect if there is any severe pain, if there is any ophthalmoplegia seen, if there is severe proptosis, if there is severe chemosis, or it's very hard to open the lids. Go with neuroimaging if you still have the suspicion but you are not sure. And if there is orbital hemorrhage that compress the globe, causing globe tinting, as is shown in the picture here in the photo. The left globe has been tinted by intraorbital edema and hemorrhage. Acute management is very mandatory. Cantholysis and canthotomy and inferior cantholysis should be done immediately as emergency procedure, and a low egress of orbital blood and the decompression of the globe. This is one of the emergencies. The second one is orbital floor fracture in children. Actually, orbital fracture in children can be roof fracture, which is usually a neurosurgeon job. It's usually associated with the CSF leakage, with some prolapse of brain tissue, or what we call it pneumocephalus as well. So we don't go with the management. So orbital roof fracture usually referred to the neurosurgery. But orbital floor fracture can be firstly an ophthalmic job, as even if it's not like surgical ophthalmic job, pure surgical ophthalmic job. Like in our facilities here, the maxillofacial surgeons are more involved than us in the orbital floor fracture. But we have to tell them when we have the suspicion, we have to identify the orbital floor fracture, and we have to decide whether this is an acutely should be treated or not. As in this picture showing 4-year-old child with inferior rectus entrapment clinically, you see the child, there is limitation of right inferior rectus, limitation of up and down gaze in the right side. So there's entrapment of right inferior rectus, it's very clear in the CT scan. Why orbital floor fracture with entrapment is an acute emergency in children? Because not like in adults, entrapment in orbital floor fracture in adults, not like emergency, it's as urgent as children, because we can do it later. We can do it even within two weeks, later than 2 weeks. They are usually waiting for the edema to subside, then we'll treat it. But in children, it's completely different, because entrapment, if suspected clinically, we have to monitor the vital sign. We have to monitor the heart rate, blood pressure, respiratory rate, oxygen, because the compression of the rectus muscle can cause vagus stimulation and even lead to fainting and bradycardia and sometimes complete heart block. That's why the vital signs should be monitored very carefully, and prompt surgical intervention ideally should be done within 48 hours if any of these signs is there, and definitely should be done within 1 week. So hopefully we can cover the most important subjects in the adnexial and orbit trauma, because actually they are wide enough to be separate in a separate lecture as well. But we have to head now to globe injury itself. And we mentioned that closed globe injury can be identified according to the zone 1, 2, and 3. Closed globe injury going from outward and inward, like for zone 1, the walls, for zone 2, to the posterior capsule, and zone 3, posterior to that. What are the common injuries that encountered in our hospitals? For me, the most important zone 1 injury, the most common actually, zone 1 injury that I encounter in my clinic or in our ED department is corneal abrasion. It's very common. Everybody can treat it conservatively, and it heals well, alhamdulillah, in children. Subconjunctival hemorrhage as well is a common zone 1 injury. foreign body that should be removed typically within 2 days, and sometimes need topical antibiotic prophylaxis, and lamellar wounds. Zone 2 injuries, the most important is the hyphema, traumatic cataract, and traumatic iritis. Zone 3 injuries, which involve the vitreous, retinal hemorrhage, commotion retinitis is the most common one, and other uncommon but drastic zone 3 injuries like retinal dialysis, tears, and detachment. So starting with zone 2, because zone 1, as I mentioned, they are very common, and I think all of us can address it. So let's talk a bit about the hyphema, because it's common, it's not uncommon, and also very important to identify it and treat it well. So if the hyphema is not coming as a meniscus, like you see the blood inside the anterior chamber, but you can't tell that there's meniscus, we call it microscopical hyphema. This hyphema can be classified actually as uveitis, like 1+, 2+, 3+, and 4+, and treated as like prevention of complication, treat the inflammation, prevent of IOP elevation, and follow up conservatively. Layered hyphema is the second category, when you can see the meniscus of the hyphema. This picture is showing an layered hyphema, which has been resolved in B in a week or so. And on retroillumination, you can see that there is associated sphincter tear. Here's why we have to know what is the mechanism of hyphema. Hyphema happens the same mechanism that causes choroidal rupture as well. It's compression, decompression of the globe that cause shear and tear to the iris vessels, and then bleeding. The same mechanism can happen to the choroid, because in case of choroidal rupture. How do we manage hyphema? As I mentioned, acutely, we have to address the acute complication that can happen. IOP, inflammation should be treated, and prevention of rebleeding, limitation of physical activity as well. We have to check, if we are not sure whether the patient is a sickle disease or sickle cell patient or not, because these patients are completely different. They should be treated carefully, they should be followed thoroughly, and sometimes need admission. 2 reasons why the sickle cell is different: because they are at high risk of rebleeding, and also because we cannot manage them well, because we have limitation in the choice of medication. Carbonic anhydrase inhibitors are contraindicated, can induce sickle crisis. Also, alpha agonists are of limited use, we cannot use them. And even miotics, if we are in need for them, we cannot use them. Subacutely, after addressing the first acute presentation of the hyphema, subacutely we have to look again for the IOP and inflammation and prevention of rebleeding, and we have to check for cornea blood stain and prevention of amblyopia. Longer term sequelae, we have to check for angle recession glaucoma and visual rehabilitation. Fortunately, most of the patients achieve more than 20/40 vision, but there is a risk of getting some visual loss in kind of 30 patients. So that's why visual rehabilitation is very important. The second important zone 2 injury, enclosed globe injury, is the traumatic cataract. Traumatic cataract can develop hours to even some books mention months later than the injury. It's not presenting acutely in most of the cases. If it's presenting acutely, you have to suspect open injury. If no open injury and the capsule is really violated, this is the only case that we have to manage acutely. Whether to operate or not. Usually, if it's early cataracts, you can't see any rupture in the capsule, in the anterior capsule, and there is no violation, can be treated conservatively. You have to address the inflammation and watch the patient for further complication and treat it accordingly. If you have a clear view and you can operate and you feel that you are not sure whether to operate or not, and the view is clear and safe to give the patient GA, go with it. Whether you will implant in traumatic cataract or not, it depends on the integrity of your posterior capsule and of your zonule. Leaving the patient FAQ with contact lens is still an option if it's not safe to give him scleral fixation, or if you are planning for secondary oral implantation because you are not sure about the integrity of your capsule. What to observe acutely or in long-term management? As in hyphema, we have to observe the inflammation and intraocular pressure, and we have to observe the vision and visual rehabilitation because it's very important. And in any closed injury, we have to look of further injuries in the zone 3 that might be hidden by the cataract. B-scan sometimes can be done. If you don't have a risk of hyphema or rebleeding, you can go with it to check for the posterior segment problem as well. Here's the zone 3 common closed injury, the commotion retinae. It's the most common zone 3 closed globe injury. It's intraretinal edema involving the outer segments, can be presenting with visual loss or visual field defects. And it can continue for weeks to months, can be treated conservatively. We have to look carefully for any associated hole, retinal tear, retinal dialysis, further hemorrhage. If not, the edema can go by itself, and many patients can be ended up with some visual loss as well, unfortunately. The second, zone 3 closed globe injury is the choroidal rupture and vitreous hemorrhage. As I mentioned, the mechanism is the same as hyphema. Here's in the picture, we have traumatic choroidal rupture acutely in the first, on the left picture, and on the right one, this patient, the same patient after 2 months of observation. Long-term management of zone 3 injury, closed injury. You have to watch for further hidden missed injuries. You have to look for peripheries of the retina as the child is coming down, and you have enough view to see the peripheries of retina. Instruct them about the restriction of the physical activity. This might continue. This might be continue up to 2 years. The follow-up and instruction of restriction of physical activity might continue up to 2 years. And again, vision rehabilitation and prevention of amblyopia. Hopefully, we cover the important subjects in closed globe injury. We can now start with open globe injuries. Again, classification, zone 1, 2, and 3. Zone 1, in open globe injury, we are going backward. In closed globe injury, we said that we are going inward, from outward inward. Here is where we start from anterior going backward, like posteriorly. The zone 1 is the cornea, when the injury involving the cornea only. Zone 2 from limbus till 5 mm behind the limbus, from the sclera. Zone 3 more than 5 mm posterior to the limbus. We have in this photo a patient who has actually in the first 2 photos it's zone 1 injury that has been repaired well. I don't think it's clear in the photo, but I wanted to explain how to address these injuries. In zone 1 injury, usually we open perilimbal wound. We don't access the anterior chamber through the same wound. We prefer to open perilimbal wound and reform the anterior chamber and address the prolapsed iris that's visualized as in figure A, and then close the wounds. The closure of the cornea is done with 10-0 nylon because the sutures having enough tensile strength provide perfect closure that can continue 4 to 6 weeks or more. And it has also minimum scarring. That's why we use the 10-0 nylon. In the same A, the second picture, after closure of the cornea, we can see that the anterior chamber is having some filtered air bubble that tamponate the wound as well. A 30% or so of the anterior chamber can be filled by this bubble. This help also prevent the further leakage. In photo B, we have zone 2 injury, which involve the limbus, periotomy, and exploration should be done to check the extension of scleral injury, and the closure of the wound should be done, like starting with the limbus, which is the landmark, and the non-absorbable suture, like 9-0 nylon, has enough tensile strength, can be used to close the limbus. The depth of our sutures should be going, the needle should be going 90% depth of the limbus or more to hold it well, and also avoid suturing the prolapsed uveal tissue. We can open, as in figure B, the second picture on the right side, you can see that the surgeon has used perilimbal suture, perilimbal incision. He went through the anterior chamber through this incision. It's at 10 o'clock. He has used this to enter the anterior chamber and cause the prolapsed uveal tissue to go back in its position. Then he repaired the injury and then filled the anterior chamber with filtered air bubble. What type of suture we use to close the cornea? Again, interrupted 10-0 nylon. The third picture, C, the patient is having zone 3 injury, which extend more than 5 million from the limbus, which was sutured well. If it's the injury itself going from the zone 2 till zone 3, you can continue the same procedure. You start with the limbus, then you close the cornea, suture the suture the anterior part of the cornea with short sutures, and try to bury them, and then the posterior part of the cornea can be sutured by longer sutures. If you are not sure whether you have open globe injury or not, you have to look for the mechanism. Very important to ask about the mechanism of injury, which gives you a hint. The visual acuity, is there any bolus subconjunctival hemorrhage, gives you a suspicion of the globe has been violated or opened. The pupillar irregularity or corktopia, anterior chamber depth is very important, asymmetry in the anterior chamber depth. Is there any shallowing or even deepening sometimes, gives a hint that the globe has been opened. If you are not sure and still suspect, don't hesitate to examine the child under general anesthesia. What's the acute management that should be done in the ED? Shield should be applied no peroral because the patient is going to have general anesthesia. For us, ATS is given routinely in the ED. We don't even ask about it because the ED physicians are doing this, but we have to ask. Analgesia and anti-emetic sometimes helpful to keep the child calm, to check your eyes, to complete your examination. If you are not sure whether there is orbital injury or not, or there is foreign body or not, you can go with CT scan, and you can start as well antibiotics as either IV, vancomycin, ceftazidime, or oral, and this antibiotic should be continued for like 7 to 10 days. As I mentioned in the previous photos, that's in zone 1, we create perilimbal wound to allow us to access the anterior chamber without violation of the injury-related wound itself. 10-0 nylon suture was used in the picture, and longer suture in the peripheries. The knots is being like 2-1-1, which allow easy burying of the suture knots. If it's not possible to bury the knots, what we will do? Sometimes it's impossible. We tried our best to bury the knot because it's really, really harmful post-op and can cause scarring in the cornea. So we have to try our best from side to side, but sometimes it's very hard to bury it because of the corneal edema caused by the injury itself. So we can, after all this trial, we can go with applying bandage contact lens to help keeping the child comfortable. And then we have to review this suture in a week or so. We should not leave it because it will cause a scar. In children, it's very easily scarred, the cornea. Don't overfill the anterior chamber because it may cause much more leakage. And check if there is any leak, applying some fluorescein on the wound and see the egress of the fluid, or you clinically just see the egress or monitor the anterior chamber, and then inject intracameral antibiotic, moxifloxacin 0.5% to prevent endophthalmitis. What if leaking is continuous? Additional sutures can be applied. Air bubble, as I mentioned, 30% of the anterior chamber can be filled with the air bubble. And you can apply cyanoacrylated glue. Don't forget that the epithelium should be debride before applying the glue, and don't overglue it. Use the Q-tip to get some like kind of drop of glue and apply it using the Q-tip to avoid overflowing of the glue on the glove. Bandage contact lens alone can be used, but bandage contact lens that I mentioned here, it's the bandage contact lens that we have to apply after applying the glue. So in the glue, don't forget to remove the epithelium and don't forget to add bandage contact lens at the end. And sometimes severe injuries, even you will try all these measures and you will still have suspicion of leakage. You go with burst strength sutures with and add to these measure as well. I think we have explained this enough. We go to anatomical landmarks of the limbus. We start with the limbus suturing it. Then the choice of the suture as well. I mentioned the depth of the needle should go 90% of or more of the limbus. And the prolapse uveal tissue should be addressed. Prolapse vitreous should be addressed. If there is vitreous, should be vitrectomy should be done. Notes and should be buried. The conjunctiva then should be revised and closed, and then intracameral moxifloxacin. Zone 3 injury starts just like zone 2. The repair is the same. The sclera is closed with 80 nylon suture because it has enough tensile strength to keep the injured sclera in position. You can try lifting the edge of the wounds to allow egress of the uveal tissue backward, and then close the sclera accordingly, interruptedly. If the wound is going really posterior, try to use the orbital retractor to get more access to it. Sometimes it's really hard to access the whole wound in case of globe rupture. If the wound is posterior and deep to the rectus muscle, we can go with repair as follow. We will remove the rectus muscle as the ideal sequence surgery. We'll remove it from the insertion, suture it and remove it, and then suture your sclera and then put the rectus muscle back in its place. Don't try to retract the rectus muscle and suture the sclera, because you might violate the wound or you violate the rectus muscle as well. Remove it as the traditional sequence surgery, suture it and remove it, and then put it back when you finish your scleral suturing. Here's how to approach special circumstances. We mentioned the traumatic cataract. I don't think we have to go through it again, because we will go, inshallah, through pediatric cataract in details later. And intraocular foreign body, when to remove it and when to leave it. If the intraocular foreign body is accessible, remove it. If it's accessible, you can remove it, go with it. If it's not really accessible or not sure whether it's accessible or not, try to find out what kind of material this intraocular foreign body is made of. If it's inert intraocular foreign body like plastic, you can leave it if it's hard to be accessed. If not inert, like copper, iron, or vegetable materials like wood, you have to address this intraocular foreign body sooner. What are the long-term measures that we have to manage later? Monitoring for the wound leak or infection is very important. Watch out for the complications. Antibiotic and steroid should be administered. And visual rehabilitation is very important. Watch for any strabismus. It's very interesting to mention that sensory strabismus can develop within even 4 weeks. Glasses, prism, surgery, or Botox to treat the strabismus, and again, amblyopia and visual rehabilitation. What are the associational injuries that should be approached later by multidisciplinary team? Peripheral retinopathy can be developed because of trauma, cortical visual impairment, traumatic cranial neuropathies, diplopia management, and concussion injuries, vestibular dysfunction as well. Here's my only reference in this lecture, because it's my, like my best friend, Taylor and Hoyt's pediatric ophthalmologist strabismus. I got the 2nd edition.
Thank you so much, Dr. Riyam, for this very interesting lecture. I learned a lot from you today. And inshallah, now we will start the question sessions. So we have 20 minutes for questions. Anyone want to ask, you can open your microphone, or you can just raise your hand for a question. Or you can write your question in the chat. Dr. Samer Khorma, he is my teacher in oculoplastic in my residency program. More than welcome, Dr. Samer. And you are more than welcome here in our small lecture. Dr. Samer, you can open your microphone.
Okay. Assalamu alaikum. Assalamu alaikum, everybody.
Wa alaikum assalam.
Dr. Abdurrahman, thank you for this talk which you sent to us. Dr. Riyam, you are a very excellent lecturer.
Thank you.
your talk was amazing. I am
Thank you so much.
57. As I said, I'm his teacher. I'm 57. I'm an old man now, maybe. I would say that your talk, I don't know your age, in fact, and I don't want to ask you about your
Mhm.
age, but it seems that you are a very experienced ophthalmic surgeon.
Uh,
Uh,
thank you.
I will,
Inshallah, I
yeah,
will
really.
experience. I hope so. Inshallah.
I will talk about the two things of interest to me. I stopped doing anything intraocular ages ago, and
Mhm.
I send these intraocular injuries to my colleagues who are specialized in this, because I believe very much in subspecialty. We
Mhm.
should all of us should be very much adherent to, to their subspecialty. There is no more Superman who knows everything in ophthalmology and who can do everything perfectly.
Yes, sure.
Yeah, exactly. I'm an oculoplastic surgeon.
Mhm.
I'm dedicated to my specialty. I would say about two things about the two interesting things you mentioned about the eyelid injuries and the orbital fractures.
Mhm.
These are the things I can add maybe or comment about what you said. First of all, regarding the eyelid injuries and the orbital injuries, I would really give a message here tonight to all of the audience that uh, oculoplastic surgery is not a weekend specialty. It's not something you see on the YouTube and you want to have a go and try your luck.
Yeah,
I've spent
sure.
now, exactly, I've spent now 23 years in oculoplastic surgery, and I feel every day I'm learning more and more. Whenever I have a very, whenever I have a tough case or an uncommon surgery, I go and read before the night of the my operation because I want to remember well what to do and to how to give the patient the best opportunity. So by no means any ophthalmologist is allowed to do eyelid surgery or orbital surgery just by default that he's an ophthalmologist.
No, no, for
Uh,
sure. But we are talking about trauma. Sometimes you are the only
yeah,
surgeons. Yeah, I'm not into doing any oculoplastic surgery. Sometimes oculoplastic surgery is even life saving. It's
yes,
like you have even you have to go with treatment of cancer. You have to go
yes,
with prevention of metastasis or extension of malignant tumor. So no, there, as you mentioned, there's no way that oculoplastic surgery can be done by general ophthalmologist or even pediatric. But we are talking about trauma specifically. That's why you are, for example, you are a pediatric ophthalmologist,
yes.
and you are the only one in there. You don't have oculoplastic surgeon there on call with
Ah,
you, so you have to address the injury. Then you might also consult, even if its injury has been addressed and treated well and suture repaired well. You might consult the oculoplastic surgeon if you feel like you are not sure whether this patient will ended up with some scarring. The suture should be removed early. So that's why, yeah, your specialty is really nice. I'm into it.
Dr. Ryan, I'm not, in fact, I'm not trying to criticize you. I'm not trying to criticize you,
I
okay,
know,
my dear?
I know.
I'm just saying common things,
Yeah,
just general information.
yeah.
I would agree, yes, that sometimes you are dealing with an emergency and there is no subspecialty like oculoplastic surgeon around you. What to do? In fact, all what you did is really correct and evidence-based and scientific. In fact, what all that
Mhm.
you mentioned, that's what I'm telling. I'm not trying to criticize you, but I this is my general advice in general in any talk. I tell people to take care while doing oculoplastic surgery. I can do squint surgery. I've done hundreds of them, but when
Mhm.
there is now a pediatric ophthalmologist like you, very well qualified, very well experienced, I'm not allowed to do elective squint surgery. So just I want to not to talk a lot. The two pieces of advice I want to say. The eyelid, which you mentioned, the eyelid injuries repair, which was very much nicely done, and your thoughts were fully correct and scientific. I would tell the audience that when you have medial eyelid injuries, you should always look for caninicular and lacrimal injuries. You're not allowed to just suture the lid routinely and say that's it, because you have to look for lacrimal injury, and you have to spend effort to make sure that the lacrimal system is intact. Uh, when you are dealing with eyelid injuries, always remember that the globe has to be checked nicely before calling this is an eyelid laceration. Make sure that there is no globe laceration. There is no any other injury systemic, because probably the patient might be a victim of road traffic accident. He might be having intracranial injury, abdominal injury, etc. So you have to be a safe, comprehensive surgeon. We are not a slit lamb doctors. We have to deal with the patient as a whole. Is
Yeah.
that clear to everybody? I hope.
Well, very clear and very great comments, Wallah, doctor. I really appreciate it. Medial injury usually you should check the lacrimal system. It's very
Absolutely.
yeah. Thank
The other piece of just comment, I hope I will cut it short now. The regarding the orbital injuries, which the slide you showed. Would you can you show the slide again, my dear? The slide of the orbital injury to orbital fracture. Can you show it again, or isn't that possible?
No, it's possible, surely.
Yeah, yeah. Thank you.
Have it here.
Dr. Abdurrahman, can you hear me?
I hear you very clear.
Okay, the question is to you now. Now I will
Okay.
not ask the lecturer. I will ask you, my once upon a time great resident, and now a scholar, a consultant probably. So I will shoot you a question now once I have the slide.
Mhm.
Is it there?
Yeah. The previous one. Yes, that's true. That's true. Yes, good. Dr. Abdurrahman, the question is to you because I don't know the audience. If we look at the CT scan, which is shown here, this is a bone window coronal view. It is showing something everybody should notice. I would say I will here disagree with you, Dr. Riyam, that this is not the muscle entrapped. This is not the muscle. The muscle cannot go all the inferictus. The muscle is in fact a little bit far away from the periosteum and from the bone and from the fracture. You can see. I want a word. I want to hear a word, Dr. Abdurrahman. I want you
Yes.
to label this fracture. Can you tell me the name of this fracture? It has a particular pathognomonic name in orbital fractures. The name of this floor fracture. It has a pathognomonic characteristic name. Anybody can tell me what's the name of this?
الوايت اي wall fracture.
That's true. But the
Yes.
fracture name, it has uh,
Trapdoor.
sorry, sorry, yes. Who said
Trapdoor.
trapdoor? Who said trapdoor? Dr. Riyam, you said that.
Yeah,
Yes.
even the Abdurrahman miss. Yeah.
Good. And one of the audience, Sarah, probably said this. Okay. I want everybody in this lecture to remember this name very well. Memorize it very well. This is by no means an average orbital fracture. This is a life-threatening problem. This is life-threatening. The child is usually has arrhythmia, has bradycardia, has vertigo, is pale, is nauseated, is vomiting. In a young child, this might be life-threatening. So, by no means, maxillofacial people should manage this fracture alone, because this is not a floor, really, there's not a floor fracture where you need to place a mesh, for example. Uh, the concept here is that this is a natural suture in the floor, which has widened because of the wave of injury. The wave of injury, the force of blunt injury has made the suture widen, and this, I mean, open the suture, natural suture has opened, has allowed some of the orbital contents, which are close to the inferior rectus, to get stuck inside this widened suture. And because the bone is membranous, the bone has reclosed on the after the wave of energy has gone, the contents got stuck there, and the child will notice something just like a click which has happened. He doesn't understand what happened, just like a click, just like a button which has been switched on or off, that the child, he can see double immediately, and he cannot lift the globe up as you showed in the slides, my dear. There's no vertical movement at all, and in up or down gaze, and the child is sick, has become sick. He has nausea, vertigo. He doesn't feel well at all. This is life-saving emergency, and you should book him on the first available operating slot on the same day or second morning. By no means you are allowed to keep him many days without surgery. Surgery is very simple and very physiological. Just under general anesthesia, do the force duction test. You will find that the something is stuck deep inside the orbit. Transconjunctival incision, identify the fracture, which is easy to do. Just widen the suture. Uh, I mean, reduce the contents back to the orbit, and make sure that the force duction test has become normal, and the surgery is done. It's a 15 minutes procedure. Unfortunately, many of the maxillofacial surgeons don't know the mechanism of the injury and the mechanism of optimal surgery. So there's no need to place a mesh, because the fracture, in fact, as you can see, is tiny. There's no gap. There's no risk of enophthalmos. It is, in fact, an oculoplastic. Maybe it could be a pediatric ophthalmologist work to do the surgery. So I hope I did not give you a headache tonight.
No, actually, it's very, very interesting, Wallah, doctor. This is my first time to know that. I've never faced this case.
Yes,
I've read about it already. I've never been involved in orbital surgery. I worked with the maxillofacial, some adult orbital fractures, but I've never been involved in such case, pediatric. Usually, you know, that orbital floor fracture that comes like it's trauma and it's wrecked, and they use mesh and, you know, screws and these issues.
Yeah.
But I was not aware that this type of fracture is just opening of the bone suture itself and then trapdoor. That's why it's called trapdoor.
Absolutely.
Just now I've learned this, Wallah. Thank you so much. Nice comment.
I'm happy to hear your feedback, and I hope everybody in the room should understand this, because, you know, my dear, many a times we had to do redo, and sometimes it's 40 or 2 months, 40 days, or 2 months post-operatively, but the muscle has gone ischemic, in fact, and the tissue has gone ischemic, and the surgery will have little or no benefit. So this is, unfortunately, we were not taught this in our ophthalmology training, that this is one of the life-threatening and one of the serious emergencies. I would say, just like rupture globe, we have all to know something about this injury.
Thank you so much, doctor. Thank you.
All right, pleasure. Have a nice eve, everybody.
Same to you.
Thank you.
Dr.
Thank you.
Abdurrahman, are you still there?
Yes, I am here.
Yeah. Tell me if is there any question for me? trapdoor. Yeah, one has answered. Yeah.
Please, Dr. Maymuna, close your camera, please. Okay, if there is any question, please, you can ask Dr. Riyam.
So it seems like no more question.
Yes.
Okay, so thank you so much. Thank you, Dr. Samer.
Assalamu alaikum.
Yes, Dr. Salam.
Excuse me. How are you, Dr. Riyam? Thank you so much for your presentation.
Thank you. Thank you so much.
I'm asking about some syndrome called post-traumatic fission syndrome. What is the best investigation to do and how to reach the diagnosis, especially if patient is comatose or deterioration in vision?
Sorry, post-traumatic?
Fission syndrome.
I don't know. Actually, post-traumatic fission.
I think something related to cortical contusion or something, and you cannot identify the lesion, especially if you find eye examination is okay.
Okay, so you're talking about post-traumatic cortical related injuries, neurological, you mean?
Yes.
Yeah, what's the name of the syndrome?
I remember like post-traumatic fission syndrome, like that.
What I know, only Miller-Fisher syndrome, but it's not post-traumatic. It's kind of ocular Guillain-Barré syndrome. What we have is cortical blindness and syndrome. We have some,
It's called post-traumatic cortical blindness.
The cortical blindness, usually macular sparing blindness. The macula is spared, so the pupil as well spared cortical blindness. You cannot identify unless you have the neuroimaging done and you know that the cortex is really being violated. I've never seen a child with cortical blindness, but I've seen an adult with
it is okay.
But this syndrome,
this macular is wherein you talk about when there is middle artery injury.
Yeah, this is this is the job of neurology. They are find the artery that has been ischemic or affected through the angiography. They are doing magnetic resonance angiography, digital subtraction angiography, CT angiography. They identify the artery, exactly which artery is involved. Actually, usually you get this patient from neuro. I got some patients as a referral from neurology for vision problem, and I got even very rare cases of progressive multifocal leukoencephalopathy. But you cannot identify it without the help of neurology, because usually needs neuroimaging and angiography specifically. Angiography should be done. But this syndrome, I have to look for it. It's a Fisher like Fischer, Fisher syndrome. Is that the spelling?
I'm not sure.
Yeah, I will look for it. I will update you, Doctora. Inshallah, next time.
Thank you so much.
Thank you. Thank you.
Thank you.
Okay, thank you, everyone. I want again to thank, first of all, Dr. Riyam for this interesting lecture.
Thank you, Dr. Abdurrahman.
And I want to thank also my teacher, Dr. Samer, for his comment, and because he is joining us today. And I learn from you, Dr. Samer, from I was resident and until now, and we will still learn from you. And you are our boss in oculoplastic. He is our boss in oculoplastic.
I'm so jealous.
Yeah.
Thank you, Dr. Riyam. Thank you, Abdurrahman, for this beautiful event. Okay, we expect more from you, Abdurrahman.
Inshallah. It's my pleasure.
Thank you, everybody.
Inshallah, we will continue in this teaching program, inshallah. Jumma Mubarakah, inshallah. Okay.
Nice meeting everybody. Thank you.
Thank you.
Bye now.
Thank you. Fi amanillah. Assalamu alaikum.